the goal of today is really to just go over the pilot site findings and talk about the lessons we learned from you all, and also talk about any next steps, and how we can make sure that we support you in sustaining your efforts to screen. If you will recall, we had the first cohort in 2017 and 2018, and you all were our first cohort to launch in cohort 2. We actually had planned for 4 sites in cohort 2, and the 4th site was the Lummi tribe in the Washington area, but due to some electronic health record issues, they weren't able to join us. So we had 3 wonderful sites. We chose PriMED primarily because Dr. Patterson was relentless. No. He was passionate, and we just felt like you all were going to be a wonderful partner. Also, we really wanted to partner with a more urban clinic, and we felt like you all met that criteria. We also had hoped to partner with a rural clinic in the South, so our Charles Henderson group met that criteria, and we wanted to partner with a large academic medical center, so Blank Children's met that criteria as well. I will say cohort 2 has been a delight to work with, and certainly I don't think there's any doubt that Jared and Dr. Patterson were my favorites. So just a refresher on the PDSA model that we use. So as part of your plan, the target audience was 3 to 10-year-olds at the well child visit. We talked way in the beginning about the rationale for picking this population. And what we heard was that there were gaps in screening for the 3 to 10-year-olds, or the 3 and 10-year-olds, excuse me, and utilizing trauma-informed standpoint was something you really were eager to do. And you also wanted to provide better support for children and families outside of the acute care and hospital setting. So it was, what we heard was when families get involved or seen in the hospital, they do get plugged into resources, but outside of that, you recognize families needed services, but didn't always have a great way to identify them and get them plugged in. The tool we were using was the ACE-Q parent report for children. We were able to get this built into your EHR very quickly as an orderable, and also able to put the toxic stress symptoms in the HPI section. And then your process was to follow the usual standardized screening workflow and then scanning as usual. I did want to make sure that we recorded your workflow correctly. Remember, throughout our coaching calls, I would often ask if anything had changed to your workflow. But in the beginning, it was handed out by the front desk staff, and then the nurses ensured that the patients completed the screener and handed off to the provider. And then the provider reviewed and made the appropriate assessment and recommendations for follow-up. And then the nurse was to document the risk. Oh, excuse me, the provider was to document the risk and return the form to the nurse. Then handoff occurred to the care coordinator, and then any external referrals were made as needed. Now you all set your scoring algorithm as we review this as part of the do section of your PDSA. With an intermediate risk of 3, because you were starting with 3 through 10-year-olds, and then a high risk score of 4 plus symptoms. I think that's important to remember as we look at the data in just a moment, or right now. I was actually referring to your Ohio data. It'll be interesting. We'll have a little discussion about the comparison there. So 11, you screened at a rate of 95%, which was um, among the highest screening rates we've ever seen. So you did an excellent job in having a consistent screening process. I imagine we don't ever expect 100%. I imagine those 5%, either the family had other things going on or it didn't feel like it was the right time, etc. You had 11% positive, which in the beginning, when I first looked at your data, I thought that that was a little bit low considering some of the information we've seen in other areas. But I go back again to your screening algorithm, which we advocate and encourage it to be individualized by each practice. But you had the highest threshold, if you will, for intermediate risk. Most other practices set that at 1 or 2 with symptoms, and so yours was high, and that's okay because you were also starting with an older age population than the other practices. So 11% is actually, I think, very accurate. And when you look at the Ohio data for ACEs, you see that children with one ACE are about 50%. So your 11% had 4 or more ACEs. So if we had set the threshold at 1, there's no doubt that we would have seen a much higher rate there, and I feel like this is very consistent with what we see within your state. If you look over to the right of your screen, right here, this 7% actually represents some of the more I would say troubling ACEs with emotional and sexual abuse. And so, we typically see this in the higher ACE scores. And so the fact that 7% of kids in Ohio are experiencing that, and you're seeing 11% with 4 or more is very, I think, very accurate and consistent with the overall data. When we kind of close out and look at the ACT component of your PDSA cycle, you screened about 250 patients in the 6 months of the pilot, which is astounding given we had 2 providers doing that screening. We know that well child visits declined significantly during COVID. And so I imagine that had that not happened, your screening rate or population would have been much higher. And I can't tell you how proud I am and how many times I share that you all took on the idea and the concept of billing. And not only did you do that, because there are actually 2 important pieces to that. Just like I always say, there are 2 important pieces to an excellent EHR build. It's great when we have an excellent build, but it doesn't mean anything if we can't get the data out. You guys also did an amazing job with that, and I got a great reports that were automated and sent to me every month. So your technology component was the most robust out of any of our pilot sites. But you were the only one to take on billing for screening, and a lot of other practices have, not in this cohort, but that we've worked with, have started billing, but they aren't necessarily seeing the reimbursement. They're seeing a lot of denials, which is okay because that is the sort of the beginning process for billing as we get payers accustomed to seeing those bills come through, and then a discussion can be had about whether or not to reimburse. You guys were successful from the start with that, so I think that's an important thing to note as a major accomplishment. Just to refresh us on the milestones of the project, we came and did training over a year ago on July 25th. You had your build and test reporting done in record time by August 9th. We did a quick refresher training August 12th, and then screening went live August 19th. And right in line with that, we had our first coaching call on September 16th. So in 2017, the Center for Youth Wellness wrote a white paper looking at the key areas of consideration for clinics when they were deciding whether they were ready to screen efforts either to more age groups or other clinic offices, or if they needed to really go into a sustainability mode and redo their PDSA cycle and make sure they could continue their efforts within their own office. And so we identified 3 domains and then several factors within those domains. So process factors where there was innovation, adaptability, and there was good data collection and monitoring were key to the success of spreading. Staff factors included engagement and training at all levels, both staff and leadership. And then organizational factors like fit with strategy and infrastructure needs. And so I did a preliminary kind of a quick assessment on your site with regard to the spread and sustainability factors. And I wanted to just make note that under the process factors, I can't give you enough praise for the fact that you were the only site to implement billing for screening. I need to add there that your site had the most efficient reporting process of any of the other sites. Under staff factors, we had the highest participation by staff and leadership in coaching calls. So with many of the other sites, I would just have the lead physician, but I always felt encouraged because at a minimum, I always had Jared on the call as well. But for 4 of the 6 calls, I had both Dr. Patterson and Jared and many other members of the team. So there was always a great dialogue about how we could improve things. And it really showed intense buy-in, and that I think has made you one of our most successful pilot sites. And then last but not least, you were the only practice to receive reimbursement for your billing efforts. And I had heard that you were already expanding screening to other age groups and talking about how to spread to other clinics. I know Jared had several questions for me. I'm going to take a peek at those in just a minute to make sure I've answered all of them. As far as the next steps, this is our ecosystem model that we're really moving forward with at CYW. Instead of doing just a third pilot site, we're hoping to do more of a whole ecosystem model. But from me, you'll get a written PDSA summary of what I've gone over. I'll also take any updates that you feel like need to be made to this presentation and incorporate them, and I'll send that to you as well. We can schedule a full sustainability assessment if you would like me to facilitate that. I suspect that Jared would do a fine job at doing that, so I will send you the document for that. so that you can complete that if you would like to. And if you'd like to engage me for that, I'm happy to do that as a part of our services together. I would encourage you to continue your data collection and monitoring. We do have our last kind of learning collaborative call on October 15th, and we would we really hope that you'll be able to participate that. And again, we would ask you to consider implementing a full ecosystem model. Okay, I'm gonna ask you all to I'm going to stop my share for just a moment so I can peek over at my email. But any thoughts or questions or corrections or additions to that presentation that you would like for us to consider? I'm just trying to get to Jared's questions that he sent me way back when we were first scheduling this.
I have no feedback. Dr. Patterson, yourself?
No, we're preparing something for operational committee here at our office, and the numbers we got that Jared, you shared with me for the number of people screened was through September 21st, and it was up over 600. Am I right?
Wow.
Yeah, it was a really high number, like 651. See if I can find that.
Wow.
So that would go through the whole year since we really started.
Yeah, that's amazing. That's a very high rate. I will tell you, you had the smallest number of provider screening, but by provider, if I did a ratio, you had the highest number of kids screened.
Yeah.
I mean, Blank Children's had they were screening 15-month-old and 3-year-olds. I mean, Jared asked me a couple of questions about where you stood in the overall, kind of ranking, and they had many more providers screening, but did not have the same rates that you did. So,
and Jared, correct me if I'm wrong, but we can actually go back and look at the number of people who scored a 1 or a 2, correct?
Absolutely.
And we can provide data that would allow you to compare apples to apples, so to speak. I mean,
sure.
Ohio data is at 1 and 2+. We can go back and chop up our data that way because the raw number that they scored was entered as discrete data. So it's not that hard to pull out those numbers. And that way we can look really at our percentages of 1 and 2+ like the state of Ohio does.
Right. You guys also had the most robust reporting.
Right. So if you could do that, Jared, that'd be great.
So can you help me understand what exact data points we need?
We need to see those who had just 1 ACE and those who had 2+, 2 or greater. Because I think we only really pulled those who are high risk, but the number is actually entered discreetly.
That is correct. You only pulled the high risk. So that 11% is actually pretty high.
Yeah, and I included some high risk that were 3 with symptoms too, because
absolutely, as you should have with your clinical judgment. But that also tells us that you had amazing rapport with your families, because you did set your thresholds pretty high, but you knew your population would be honest with you. So I think that was a good insight on your part, Dr. Patterson, because you got the data you needed to help families be be referred and successful in their efforts
Yeah,
to get help and to do better. I thought that you had one of the best stories as well. I loved the story that you shared about the mom, the grandmother who had been to a developmental specialist with her child,
well, actually, it was an
and the
adoptive mom.
developmental she shared. Oh, okay. Well, you tell the story because the rest of the team hasn't heard it.
Um, First, I think that my rapport allowed parents to fill it out. I'm not quite sure they was always honest. But this mom in particular, I just saw him actually again last week, and he's continuing to do better. He was a child who was drug-exposed infant who was born a little premature and entered into the care of this adoptive mom. I think he was about 4 months old, something like that, 4 to 6 months old. She's had him ever since, but he's having ongoing behavioral issues. He's in occupational therapy for sensory integration dysfunction. Cognitively, he's actually doing pretty good. But when she saw that I was asking these questions, commented on how she was glad that we were looking at these questions, in part because when seeking care for his behavior with the developmental and behavioral clinic here at the Dayton Children's, the nurse practitioner who saw her felt that all the stuff that happened to him before shouldn't matter anymore. And she, through her research, had really felt that it should matter, and that the caveat, the body remembers, is one that's in place. So we sought her new guidance. You know, I tried to actually get her in to see the developmentalist, pediatrician, not the nurse practitioner. The clinic kind of pushed back a little bit, but we actually got her into another children's hospital not too far away. And she's now following up with them, but she continues in some occupational therapy that and behavioral therapy that we got her plugged into. So parents are paying attention to this more. And overall, I'm actually finding more parents willing to seek counseling, not just in this age group for this problems, but overall. I think people are seeing how tough things are.
Yeah. Dr. Patterson didn't say the part that warmed my heart, and that was that the mom actually said, well, you know, why do I need to go to the developmental specialist? You seem to know more about this stuff than they do.
Yeah, she did say that.
You weren't going to take credit for that, but I remembered.
I'm just trying to pay attention.
Yeah, yeah. Well, you've done an amazing job, and one of the questions that I just refreshed my memory, Jared asked was, are we, you know, what is the term of our engagement? And technically, this is the end. We are always here for you guys, and would love to hear from you. But we really consider the 1 year mark the end, and you've certainly met that. And any final invoicing that you need to do to get reimbursement for us, you should go ahead and do that. Make sure that you've billed for your full stipend. And really the hope in providing you with these documents is for you to use them however you see fit, either with funders or starting your own resilience coalition in the community, or garnering interest for that. I mean, you all would be wonderful leaders in that movement, and I think just making families in the community more aware is really part of the next step in the ecosystem. Even getting moms like the one you've just mentioned, Dr. Patterson, to be on that advisory committee and help talk to other parents about that, I think would be really a great next step for your community. And certainly I have no doubt that you all will be very successful in the future. Do you have plans to expand to all ages, or have you already done that for screening?
I haven't formally started doing any other age groups. I think I'm going to keep this process in place for the 3 to 11. If I expand formally, it'll probably be expanding upward to the 12-year-old and the teenagers. I think that one thing that this has gotten me a little better at is identifying some of those ACEs that may be present without them necessarily filling out a piece of paper.
Yeah.
And doing a better social history, and especially when in regards to babies. Our intake process is so heavy laden with forms that I always resist adding another form to fill out. I do want to change from this tool to Pearls, which really is the same question.
Yeah.
But I'm gonna probably mock up a copy of the Pearls with our logo and use it that way.
Perfect.
Is there any copyright issues with that?
No.
Okay.
It's available on the ACEs Aware website for free, so no, there's no issue. And Jared, good news there. You won't have to change anything in the electronic health record recording part because the scoring is the same.
Same, right. Yeah.
I also have a couple of data points to follow up on. I have my record right in front of me, talking about, and I apologize if I'm jumping back too far, but the number of ones that we had as well as 2+. So one thing I wanted to check on too is the number of screens that you guys just showed a little bit ago. But what I'm showing here is that we had a total of 611 screens performed, 322 of which were zeros, 125 were ones, and then the remainder, 164, were 2 and above. How many screenings did you show, Carissa?
Well, I had 250, but that was just for the first 6 months. So November through February.
So that pace would be kind of about the same.
Yeah, absolutely.
Up to 500. We might have gotten a little bit more. One of the things we continued to see patients through the pandemic, and what we tried to continue to see were babies who needed it in school, early school age children who were still needing vaccines. So we probably still saw a fair number of people 6 and under during that time. So we probably got some more. And here over the last month or two, I've just been doing tons of checkups. So that's probably increased our numbers compared to what we were seeing in November, December, January, February. That's the time of the year when I can cut down on checkups anyway.
Yeah. But we actually started screening back on 9/1. So even more were coming through before November.
For that last 6 months, yeah. Right.
Yeah.
Okay.
Jared, how many did you say again had a 1?
I, again, remember this is September through 9/21. I have 125 ones.
So the total number was 611, 125 ones, and how many 2+?
164 2+.
So that's right at 23%. So that's completely consistent with your Ohio data.
And then 322 zeros.
Yeah. Completely consistent with that Ohio data.
Okay. Yeah. And you said you can send us the presentation you did today?
Yes, sir. Absolutely.
Great. Thank you.
And I will also send you, we have those patient education, like what are ACEs and those handouts with pictures of adolescents, and they've been reformatted for an adolescent population. So I'll send you those as well if you're going to start screening the older kids.
That'll work.
Yeah. Good deal. Well, we certainly are. I'm going to miss talking to you guys every month.
Yeah. We appreciate all the work that you did. We'll miss you as well. And hopefully we'll find a way to work together at some point in the future.
I was
We
going
would
to
love
say this is definitely not goodbye. I assure
Right, right.
Well,
And
good.
if you guys need old gray-haired pediatrician to talk about this, just let me know.
you.
Oh, Dr. Patterson, we're going to take you up on that.
Yeah, I'd be more than willing to do that. This is something that's important, and I think the importance is becoming more visible as time goes by. So
Absolutely, absolutely. We do have we are having a lot of discussions about how we can revamp. I believe it's the last question on the bottom section, the more social determinants section, to really address racial inequality and oppression and racism and 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 how important that is to capture, especially right now, um, and to have good conversations around that. So,
okay, good stuff.
yeah. All right. Well, thank you all for your time. I'll be sending a couple of things your way, and we look forward to seeing you October 15th on our last Learning Collaborative call.
All
Thank
right.
you.